Welcome to The Right Chamber, the podcast that takes you inside the NHS to explore what really makes a hospital.
Each episode, we sit down with the people who keep healthcare moving, from doctors, nurses on the front line, to students, the support teams, administrators, corporate staff, and everyone in between. These are the voices that often go unheard, but together they form the heartbeat of our hospitals.
Our aim is simple: to share authentic stories that are accessible to the public, meaningful to NHS staff, and a reminder that healthcare is more than treatments and wards. It's a whole community working together.
So whether you're part of the NHS family or simply curious about the people behind the service, join us as we open the doors to the conversations that matter here in the Right Chamber.
Ruckie Kahlon, Chief Pharmacist and Associate Director of Medicines Optimisation at the Dudley Group NHS Foundation Trust, has over 33 years experience in pharmacy, a pioneer in cancer services, prescribing and service transformation. She led the Trust vaccination programme and pharmacy redesign. A Fellow of the Royal Pharmaceutical Society, she chairs the West Midlands Chief Pharmacist Network and advises regional and national pharmacy leadership on innovation and workforce development.
Welcome back to the Right Chamber podcast. My name is Jasprit.
My name is Victor.
And today we have Ruckie Kahlon. Could you do a little bit of an introduction about yourself?
Sure. I'm Ruckie Kahlon. I'm Chief Pharmacist at the Trust, and I'm also Associate Director of Medicines Optimisation, which means I work very closely with the Medical Directorate to ensure medicines are used appropriately across our organisation. I'm also the Control Drugs Accountable Officer. So it's a role that is mandated in every organisation that involves themselves in controlled drug administration, prescribing and so on. And I'm a superintendent and the head of pharmacy services. So lots of different responsibilities and accountability around medicines for the Trust. And I've been at the Trust celebrated last month, 25 years. 25 years.
Did you start in this trust?
So I started at Sandwell West Birmingham as a pre-registration pharmacist. So I did my degree at the London School of Pharmacy, fantastic 3 years. And then I did my pre-registration year at Sandwell. So I'm definitely a Black Country a pharmacist. And it's taken me on to work at Stafford and Stoke. And then I came back into the role at Dudley Group as the lead pharmacist for cancer services. And that was the first of its kind in this trust at that time. And then I became chief pharmacist about just under 9 years ago. And the opportunity really grabbed me, and I've not looked back since.
So what exactly is the role of a chief pharmacist?
The chief pharmacist has a statutory responsibility around the medicines provision. It's directly delegated from the chief executive. The role is to ensure the provision of medicines is done safely, it's with a quality-related service, and it looks after all aspects of medicines. We know that patients coming into our organisation will need a medicine. And I would say that majority of our patients will come in with either a prescription or a radiology request of some sort or a blood test of some sort. So it's as common as a commonest modality of therapy. So medicines provision from prescribing, how safe is our prescribing, the quality of our prescribing, and all of those things associated with prescribing, through to the ordering of medicines, how we order them from manufacturers and suppliers, how nursing clinicians order medicines, how we administer medicines, and how we dispense medicines. So all of those facets of our medicines are what I'm overall involved in. The medicine safety program, antimicrobial stewardship, all those things are associated with the chief pharmacist role, alongside managing a service and managing that service, and the quality assurance at ward level and clinical level. So those responsibilities sit predominantly with the chief pharmacist through delegation.
So you're quite involved in almost every aspect of the service. That is brilliant.
So we're like an Optimus. We sit in every single service. There are pharmacy professionals, as I've done in the last 9 years, embedded into all teams to ensure that we are there, present and available to provide advice, guidance and support. We're actively prescribe and actively participate in clinical aspects of everybody's role. So we're everywhere: maternity, emergency department, theatres, surgery, medicine, support services, imaging, endoscopy areas. So we're everywhere, as we should be, working side by side as a multi-professional.
Brilliant. Brilliant. And I'm glad you mentioned that as kind of the multi-professional team that the hospital is. A lot of our listeners will be staff members, perhaps might even also we might have some community listeners as well. So just to kind of break it down a little bit, I guess when everyone kind of or how I thought about pharmacy, immediately you think about drugs and medications and prescribing. But actually, there's a lot more as we're gathering. It's a whole service. So tell us a little bit more about, pharmacy as a service and the teams that are involved.
I mean, the pharmacy directorate sits within the core clinical services part of the division, so the triple CS division. And within that, we've got around 184 staff, just under whole-time equivalent, should I say, around 200 people. And there are a couple of registered professionals. So the pharmacist is a registered professional with the General Pharmaceutical Council, and so is the pharmacy technician. The pharmacist is a registered through multiple degrees, often, but lots of postgraduate qualifications. And the pharmacy technician route is through an MBQ route. So they're very different roles, but they work completely together. They work as a complete unit. Alongside that, we have non-registered professionals called pharmacy assistants and pharmacy associates. And then we have pharmacy apprentices coming through to support the technical side of things. So the technical arm is managed by those staff, the clinical arm predominantly managed by pharmacists. And we are now starting to bridge the gap between pharmacy technicians and pharmacists at clinicians. So pharmacy technicians are becoming much more clinical in their role, involved in patient group directions. They're involved in clinics. They work actively across all of our clinical areas. You'll have a pharmacy technician come to you after they've done a medicines reconciliation, telling you these medicines need prescribing. So they're much more into the clinical arm. As for pharmacists, they are clinicians. They've done a pharmacy degree, postgraduate qualifications to enable them to work absolutely part of the multi-professional team, advising, guiding, supporting, prescribing as well. And often, I think traditionally you get confused between those two roles.
100%, because I would always think that whoever comes to me and asks about medication is a pharmacist. Period.
Yeah.
I didn't know there were I didn't know there was pharmacy associates, technicians, or if someone said that they were pharmacist technician.
To me, that just means pharmacist.
Yeah, because they're literally telling me the same thing as a pharmacist. So I would just be like, okay, that's
so they're all complement each other. So that the remit of the responsibility and the accountability of pharmacists is very different to that of a technician. However, the two can't work without each other. The technical elements are done by the pharmacy technician, and I think it's very akin to, for example, registered nurses and healthcare support workers, for example. And now you're starting to see other associates working within the medical profession. So it's very similar to that approach. The difference being here is that they're both registered professionals with General Pharmaceutical Council. And both are pushing the envelope of what they do. As pharmacists now, as of this last year, are coming out of the university with their 4-year degree with a prescribing readiness. So in that pre-registration year, they will convert to become a pharmacist prescriber at the end of that year. So as they do their pre-registration year exams, they'll also become a pharmacist prescriber. And that's something that is brand spanking new, and is going to really revolutionise the way we do education and training. And this is following the initial education training transforms that have occurred within the pharmacy profession. But if we're doing that, we need to have underpinning elsewhere. So the pharmacy technicians are now starting to take some of the traditional pharmaceutical roles that we were undertaking of years past. And that's a really good transition, because that gives them further areas to explore. And then we're utilising non-registered staff to mitigate any gaps created elsewhere. What we're talking about really here is ideally skill mix, isn't it? You're really getting people to work to the best of their ability, getting clinicians to really spend time on patient-facing activities.
I'm so confused. So this might be a silly question. I thought pharmacists could always prescribe. When on EPMA, you get the props. So obviously a pharmacist says, put those medications there and we just need to authorize it. So they're not
all. So
Not all.
At the Dudley Group, we're probably earing towards about 80% of our pharmacists are prescribers now, which is brilliant. It's music to my ears. And I have to say at this point, I was the first pharmacist prescriber in the trust back in 2009. So, that was the test case, I think. And I'm privileged to work alongside an eminent oncologist for about 7 years before I took on the role as chief pharmacist. And that's where I really, really, truly understood that the multi-professional working, I think that's where I really cut my teeth. So working in an oncology clinic in breast cancer and ovarian cancer. So the pharmacists we have now are working in a myriad of specialties. We've got a pain pharmacist who works with a consultant a parallel clinic working alongside them. We've got pharmacists within oncology and hematology, and a whole myriad of pharmacists working at ward level. So some of the pharmacists that you might be coming across Jasprit will be pharmacist prescribers now. So, and in a very short amount of time, I think we'll be in the 90%. There'll always be some from previous years who've not transitioned over, who feel that they don't need that in their role, because you don't have to be a prescriber. There's so much that us pharmacists we can do around medicines, advice, and so on, and we just need the a prescriber of some sort to transition the whatever their recommendations are.
So what do they actually need to do to become a prescriber? I assume it's not just a test.
No, so it's a diploma. It can be a diploma, it can be a certificate. So it depends on what route you take. You have to be a registered pharmacist first of all. You have to be practicing, and up till now, and now we've changed that as through the initial education standards. So up till now, we've had to be a registered pharmacist, and you had to be practicing. Through the changes in education standards now, pharmacists will be coming out of pre-registration pharmacists will be coming out of university with readiness. So the core education they've got has changed considerably to cater for the clinical elements that you would have done in the postgraduate level when I did it, for example. So pharmacists will need to do 90 hours of practice alongside a designated prescribing practitioner. That could be medical, that could be a pharmacist. When I was doing it, it was only medical. So I worked alongside the oncologist for 90 hours to make sure that I understood all the prescribing elements that they were involved in. You have to remember, you're starting in a very different place. We already understand everything around medicines. We're medicines experts. So what are we really learning here? We're learning how clinic etiquette works. How does it work in terms of the ethical dilemmas you have around prescribing? How do I manage the guidelines in that specific area? But we are from a different point. We often know all these things already, but you're working in a very different way. What we truly are learning is the actual patient-facing role, because whilst we are patient-facing, it's very different in terms of diagnosing, touching the patient in a very different way as you were than beforehand. So, doing diagnostic skills, doing full body screening, for example, when you're assessing a patient for chemotherapy impact. So that's a very different skill than you would have had beforehand. And then it's on the job learning. And so after that completion of those 90 hours, there's a whole host of other work associated with the portfolio, reflective portfolio, various assignments, audits, dissertations associated with it. So it is a formal certification, and not just a few hours of training. It's a very in-depth program.
So how long is it usually?
So normally it would have taken you a minimum of 6 months of learning, and then assessments. Whereas now, as the pharmacists come out of university, all of that is embedded in their 4-year program. They'll be doing all of that through that time period, and then the assessments now will be through their 90 hours with contact time.
So it's like a lot of changes over the last 10, 15 years in the role, and it seems there's higher levels of competencies at much earlier in the phase of kind of your professional role and your professional life. So right from even prior to graduation, what we're going to be seeing now is graduating, with probably in the 90% of you mentioned of pharmacists already prescribing, and that will kind of change the landscape as well as how the roles will start to look.
Yeah, absolutely. The landscape is definitely starting to change already. the numbers will sort of slowly come through and permeate, won't they? They won't happen all of a sudden. So roughly there's around 3,000 pre-registration pharmacists, trainee pharmacists every year across England. So in any one organisation, there's only going to be a couple. We're very privileged that we have 8 per year. We may have to reduce some of those numbers over time as the numbers change and the finances change. But to 8 new trainees that may or may not choose to stay with us, although we actively support them to do so. So it will slowly change. It's not going to happen overnight. I think the organisation already has benefited by having those pharmacists do prescribing, because it transforms. You haven't got to wait for somebody to come along to change something. You can actively change something, and you have the skill sets to do that, and you've got the mandate to do that. And when you're working in a multi-professional team, you're already going to have an agreement on that. But certainly the landscape is going to change. With that, though, as a head of service, I worry about what they're not going to be doing. So therefore, we've got to make sure that the pharmacy technicians are equipped to support that. So we've been doing some of their education reforms as well, to enable them to become clinicians and broaden their skill sets. And then what about managing a pharmacy service? How do we manage those 200 people in that department? So just to go back to pharmacy consists of around 11 teams through medicines optimization, medicines procurement, for example. We have a pharmacy aseptic unit where we make systemic anti-cancer therapy doses for our patients on the oncology dedications and on our oncology and hematology ward areas. And we have a whole raft of clinical trial research teams, antimicrobial stewardship team. We have a huge clinical pharmacy team that roam across the whole of the hospital department. And then supply. We do medicine supply through our dispensaries. So we have 3 dispensaries across each of our sites. And then we have a distribution team to make sure that medicines get to the right place securely, safely. So there's a whole myriad of teams, of small numbers, large numbers. Predominantly the biggest team is the clinical pharmacy service. And then alongside that, they have dispensing hubs on various areas to enable close to patient care as much as possible. Alongside all of that are pharmacists in clinics and attending ward rounds to enable patient care. So yeah, we're working closely with our resident doctors. We're working closely with our registrars and with our consultant teams, and embedding wherever we can. My joy is when people are embedded into the team entirely, and they live there and they work there and they're part of that team, because that's where the real magic happens.
Yeah, we always know our ward pharmacists.
Yeah.
Oh yeah.
I think it's very important when they join the ward rounds. That isn't very common sometimes, but I think if you make them feel welcome, and it's important to have someone from the pharmacy team on the ward round, just in case like someone says pain's not in control, this medication, that medication, you have a professional there to tell you what to do.
Yeah, we'll just enable smoother running
Yeah.
of the service overall. But yeah, that's very interesting to learn. There's the face that you see are the pharmacists on the wards and the technicians on the wards. But actually, yeah, there's a lot more to it. There's the procurement, and then there's the monitoring and checking that things are in order. Then there's the actual working within the clinical team, and then the dispensing aspect of it. So 11 teams within the pharmacy. I would not have thought about that.
So the medicine spend is around £60 million. This is a huge undertaking, a huge responsibility. So other than staff, in terms of financial spend, medicines become some of the second most expensive element to any hospital. So ensuring that we get the right medicines at the right time, at the right dose, and the right frequency are really important for the right patient. So there's a huge infrastructure associated with the medicines provision, and ensuring that we supply medicines accurately, safely, and procured at the best value. With this is ensuring that we use our funds very sensibly. It is absolutely our mandate, and that's one of my top responsibilities, to make sure we do that. We buy medicines on frameworks. We ensure that they are quality, they're high. We see so much on social media around medicines that have been tampered and fraud and so on. We absolutely ensure that those medicines are of the highest quality possible, to make sure that patients are safe at all times. And we know supply chain is so difficult around all the things that we have in life, but medicines particularly. And we've got to make sure that if we can't get hold of drug X, that we can get hold of a very similar product to ensure patient continuity. And we already know that patients have to be on certain medicines for life. Immunosuppression, for example, we've got to make sure that we don't have a break in therapy, particularly with time-critical medicines. So the responsibility we hold is a considerable one. But we can only do that working in partnership with doctors and nurses. That can't happen without
Yeah.
support.
Absolutely. Because I'm thinking about, on the point of procurement, there are times where, I might get an email coming to say, oh, this certain medication is actually very difficult nationally to get hold of at the moment. Perhaps stop prescribing it IV if the patient has the capability to take a certain medication orally, and perhaps the bioavailability, so how much is ending up in the bloodstream, is the same. So actually prescribe it this way, it'll be better, and we can save money at least until we can get more of this medication on board. So in that sense, you can see the partnership and how it's really important. And it's not just guidelines say give this and then give, but actually there's more thoughts that can go into what route you give certain medication, what is the best, as you said, quality and highest quality to give for the price that is also the most, is it ethical that we'll say, or just affordable, but still ensuring that quality and that patient safety is at the utmost priority.
Absolutely. We're probably grappling around 200 medicine shortages at any given time. That's a huge undertaking and a concern, and it could very easily become a patient safety issue. So what we have a very, very clear structure approach about how we manage medicine shortages, because we cannot take the eye off the ball on this one, and because they will lead to harm. So there is the medicines procurement team will work very closely with the directorate of pharmacists. So not only have we got pharmacists at board, they will also carry a responsibility for a specific directorate. So for pain medicine, for example, I know that you're working closely with those. If a pain medicine became unavailable, then the directorate pharmacist, who has specialty understanding, who really gets the pain ladder and knows exactly what other alternatives could be used, will work closely with the specialty leads there to say, look, this medicine's not going to be available. This is how long it's not going to be made available. Do we pull back the stock for those that we absolutely cannot switch over to another product? So we're conserving stock. Yeah. So that's why you'll sometimes see that lots of activity going on in pulling the stock back from all the other areas. But if we do that, we need an alternative. So they'll work very closely with the clinical team, the pharmacy procurement team, to ensure that we buy quality assured unlicensed medicine, for example. So it's licensed in another country, but not licensed in the UK. So not completely white label unlicensed medicine, or an alternative product that is available in the UK. Clearly, we will always go to licensed medicines first, because we want to make sure quality and safety for our patients. But there's an industry of work associated with every single medicine and monitoring that. And it can come into stock for a short while, then go back out of stock for a while. But one thing I have to say is the partnership working is absolutely brilliant. And I measure the effectiveness of that, the number of phone calls I might get from unhappy people. And I have to say, I've had 0 this year. So it just shows you the partnership working, the guideline writing together does make such a difference, because you're sorting the issue out at source, and you're taking a very patient-centric approach and looking at all the different scenarios that patients might be presenting. And I think that just tells you how good the partnerships are, because I don't get the complaints. And that's how I measure how effective it is, clearly.
What I want to make sure we touch on is also controlled drugs, and there's a accountability, as an accountability officer. What does that look like in terms of controlled medications? Because we have what we're taught at medical school, of this is how you prescribe, ensure you write this out. Even in theatres, we make sure we count out medication, what's being used, what's not being used, make sure things are disposed of
two-pass and check
properly.
and everything.
So where does the pharmacy then come into that?
Okay. So the Controlled Drugs Accountable Officer role was created following the Shipman Review, as you may not already be aware, where sadly the abuse of position from a GP led to significant harm and criminal case that came through that. Following that, the accountability of how medicines were managed came through that there were clear weaknesses and people not sharing information. So the CD Accountable Officer, the Controlled Drugs Accountable Officer, is national, and they are based regionally, and then they're based locally. And every organisation that is handling controlled drugs must have a designated body, must have a Controlled Drugs Accountable Officer, and that joy just sits with me. What does that really mean for us as an organisation? That we are meeting the misuse of regulations for controlled drugs, and those regulations are steeped in history. They've been tested recently to say, are they still fit for purpose? They clearly are. But in practice, that means that there has to be oversight on the way we manage controlled drugs. So it's an extension of what I do as the chief pharmacist to a certain extent. That are those medicines prescribed in accordance to guidelines? Okay. Are we using them appropriately? Can we account for every single dose? And can we see evidence of that happen?
It's kind of like a constant auditing that's going on.
Constantly, it's a constant chain of events, isn't there? So you will be at a clinic level or in theatre level, you'll be having stock registered to your environment, and you'll then maintain that stock to see that it's being used appropriately. So that's a little bit around stewardship, but really more about preventing the risk of diversion. These drugs, if misused, can cause dependencies, as we've talked about previously. They can cause harm, and they can be misused and misappropriately applied to others. So we've got to make sure that we don't have those things happening in any of our designated bodies. So it is a lot of work, isn't it? You spend an awful lot of time checking in and out, and sometimes we don't understand why. The why is that these drugs can cause harm, and they can be diverted. And as a result of that, because those two things can happen, we have to put the safeguards in place. And the accountable officers are there to ensure that that is happening. So we have policy, we have procedures, we apply audits around those policies and procedures. And hence why you'll see pharmacy professionals coming in, working alongside ODPs and our nursing colleagues and medical colleagues to make sure that those things are in place.
And it's actually quite useful when pharmacists come back and tell you that you don't need to prescribe this. When patients go home and we prescribe certain amount of opioids. So it was always nice when a pharmacist says, look at that drug chart. They haven't been taking it. You don't have to send them home with this stuff.
Yeah.
So yes, I think pharmacists make our lives a lot easier than we know.
Yeah, definitely. Absolutely. You want to make sure you know your ward pharmacist and have their bleep numbers the second you step and start the shift.
And also that there's pharmacy technicians and assistants.
Yeah.
Get to know what role they're in.
I think it's important that it's done, mutually, that we absolutely introduce yourself. So when I was a jobbing pharmacist on a ward, the first thing I would do is when the rotations had occurred, I'd go meet the new resident doctors coming through to say, hello, who I am, what am I here to help with? And I'm only going to ever bleep you for this. So it's serious. And then I'll be leaving you little notes to say what I need you to do if there's anything, and if there's anything urgent, we'll obviously catch up. And it's really important to have that sort of that trust and that relationship. And I have to say, I absolutely loved it. The entire time I've been a jobbing pharmacist, those relationships have always been really positive because
I've never had a bad pharmacist.
Honestly,
Honestly, they're always really friendly.
Yeah. I can remember as an F1, I'd call the ward pharmacist and just be like, I don't know if this is a question for you, but I'm a bit confused. Are you happy? And they're always positive to just help. And even if they can't help you specifically, they'll point you in the right direction. So it's such a
I've ran
great
pharmacists for
relationship.
like technical issues when I can't prescribe something. Why can't I prescribe it? It's always because like EPMAs nowadays, like they sometimes think that's a drug that you have paused or stopped is still in the system. So it doesn't let you prescribe something that's equivalent of it, like anticoagulants. If you've
stopped, like a Pixaban or something, they will not let you prescribe enoxaparin. Like, please, this patient needs it. And always ring the pharmacist. They know what to do.
So we're close to the digital systems, aren't we? So there's a team in the department that is a digital medicines team that works very closely with our digital trust, for example. So we deployed our electronic prescribing system in the middle of COVID. It was a significant undertaking, but the most multi-professional thing I've ever come across. After we had cut over 700 patients in the organisation, at 9:30 we all got together and enjoyed each other's company with a pizza. So that's pharmacists working with nurses, working with medics. It was the most joyous thing. But what it does do, it provides us great opportunity to improve our data sets, understanding why we're prescribing what we're prescribing, where we were doing it, really enabling our clinicians to prescribe wherever they are, so that we're not stuck to a specific environment, and having more fluidity and flexibility in the way that we work. What it does require is a better understanding around digital systems, because digital systems can be difficult for people to understand. So there is a new piece of work happening around digital medicines, and how we can improve that. So, for example, we are now looking at moving into outpatient prescribing in the near future. So we've got digital system in that area, and then also to looking at the prescriptions that you see with GPs, the FP10 prescriptions, the green prescriptions, to utilising a digital version of that, and working with our current supplier to enable that, so that we've got one big prescribing system to enable that. So we're definitely moving into the digital space. Within pharmacy, we're very automated. We have pharmacy robots, for example.
Wow.
And those pharmacy robots, when we first deployed them back in 2001, relieved us of 3 members of staff. We didn't need those staff, and we redeployed those 3 members of staff into clinical areas. So those pharmacy technicians were the birth child of the robot, being able to be at ward level, for example. That was brilliant. And so that's where medicines reconciliation really took off, that pharmacy technicians were supporting the skill mix of pharmacists so that they could move on to doing more clinical work. But so the pharmacy robots, we just had those replaced a couple of years ago. And what they do is they store as much of our medicines that can be stored at ambient temperature, for example, and they have got sensible picking heads that pick those medicines. So if you have a prescription present to you, you're able to go to your PC and you're able to pull those medicines, and they'll pick those medicines for you, and they come through a very convoluted tubing system, and they will drop in front of you, of which then you can then apply labels. That stops you from going to have to find them, improves accuracy, quality and time saving, and it absolutely revolutionized the way we work in our dispensary.
So it's not a wheeled robot going around.
No, not at all.
Just
It's
doing the work.
it's a very static, large device. And if you look at it, it's so impressive because it's got rapid moving arms. It's got a sort of slower moving areas, and it's really revolutionized the dispensing process and the accuracy of that dispensing process. And it means that we can give patient experience, really do some good work on patient experience as our patients are waiting, and they can see those things happening around them in our dispensary.
And I think what you said, like having digital pharmacy is revolutionary, because going back to times when we used to have to fill in paper charts, could cause a lot of mistakes. Or as we're going to call it, learning opportunities. But this is what we're going to talk about in another episode.
I'm sure our listeners, just as I have been enlightened by just how wide the pharmacy department is. So yeah, absolutely. I think we need to spend some time to get into the nitty-gritty of actual prescribing, and as we said, learning opportunities as well from that, from mistakes and how we can improve from that. So definitely we'll have to either get you or more people from the pharmacy department and to talk about that. Thank you so much for coming on and just sharing about the pharmacy department. Definitely
the world of pharmacy.
Definitely, we've all learned something.
It's been a pleasure to indulge
enlighten us.
Thank you. Thank you very much.
Brilliant. So thank you all for tuning into the podcast today, and we will see you on the next one. As usual, interact with us, comment, like, and if you are keen to get involved, also get in touch with us. Alrighty.
See
Till
you
the
next
next one.
time.
Remember to stay connected with us on social media. Follow us on Instagram and TikTok at RGUCMS. And subscribe to our YouTube channel, RGUC Media, for more exclusive content and updates. Thanks for tuning in to the Right Chamber podcast. Until next time.